concerns infection control measures in hospitals, biomedical waste management. The point I would like to highlight here, and as I was earlier mentioning, that there are states which are reporting increase in the case fatality rate. Karnataka, Jammu and Kashmir, Chandigarh, and Tamil Nadu. And if we kindly see here, the first graph, all the states which are in red color, they are the states where the case fatality rate is higher than the national average. So the point to highlight here be Gujarat, Maharashtra, West Bengal, and Delhi. These are the states where the national average is high, the case fatality rate is higher than national average, and in turn they have an impact on the overall national average of number are getting reported. Second point I would like to highlight within this particular slide that if we see down below, this is the case fatality rate in few other countries. So if we were to see, the states like Maharashtra and Gujarat, they are performing as bad as Brazil. Gujarat is performing as bad as USA and China, etc. So this is a cause of concern. That is why we all need to start focusing on what measures to take up so as to save life. Second is with respect to all those bars which are in the second graph, which are in brown color. They are the states where case fatality rate can reach high. If we can kindly mute our mic. So where the case fatality rate is time. So can I kindly request everyone to keep their mic in mute mode so that there is no resound, please? Kindly continue. So Karnataka, Jammu Kashmir, Chandigarh, Tamil Nadu are the states where the fatality rate is. Second point in the next slide, I would like to highlight another important area of focus is with respect to high healthcare worker infection rate. And if you see overall from the ICMR data, we try to analyze it and we see that it might be much bigger than this number. But if you were to just take the first cut analysis based on the ICMR data, Maharashtra, Delhi, Tamil Nadu, Gujarat, and Karnataka, West Bengal, these are the states where higher healthcare workforce infection has been noted. And as an overall percentage of the total cases in the state, again Maharashtra, Delhi, Gujarat, West Bengal, Haryana, and Madhya Pradesh, the overall percentage of the healthcare workforce infection is also very high. So these, again, as you would appreciate, next slide, will have an impact on the system capacity, low morale for the workforce, and further infection spread by the healthcare workers themselves, delay in diagnosis in case, and it can then overall impact the case fatality rate. If you were to see the next slide is primarily which are the worst affected districts, where as per the ICMR initial database when we analyze, which have reported more than 400 plus healthcare workforce infection, and also where high case positivity is noted. So this is all the districts in Delhi, Mumbai, Thane, Chennai, Pune, Ahmedabad. So just to highlight that, again, these are the districts which particularly in the states identified need to focus on the healthcare workforce infection. And we finally come to highlight the point that we need to keep continuing our focus on infection prevention and control, review all administrative setup in hospitals, including cleaning and sanitization protocol in treatment facility, focusing on operation theatre labor lab, and also creating a mechanism where there is a proper and effective communication among doctors and healthcare workers. Request DJJ sir will continue further, but I would request Director Aiims to kindly take over something. Or DJJ sir would like to.
So all the topics which are listed are, and here is a report from Karnataka that one doctor will not be admitted and he lost his life. So I request Dr. Bugaria to please to the further proceedings.
The participants who have actually logged on to the Center of Excellence webinar today. I think, as is already mentioned by Mr. Lavarwal, our main aim for the Center of Excellence is that all of the mentoring institute should work as a team, try and educate people in your state so that we can really save lives and bring our mortality to less than 1%. It's something that can be done. But while we do that, it's also important to protect workers. And very often we talk about topics which are more interesting: testing, what is the role of rapid antigen tests, what is the role of antibodies, treatment strategies, newer drugs, remdesivir, tocilizumab, plasma therapy. But I think the backbone of all management of COVID rests on infection prevention and infection control. And every hospital should have a very good hospital infection control team. You should have members from all parts, that is, all healthcare workers, whether you are residents, doctors, nursing officers, or OT technicians, or the other staff should participate. And when we talk of infection control and prevention, it means every person who is getting exposed to a COVID patient must be properly trained in infection control, whether it's donning, whether it's doffing, whether it's simple measures of hand washing, how to actually just wash your hands properly so that it's done in a proper manner, or how do you really look after yourself in both COVID and non-COVID areas. So there are a lot of challenges, and sometimes we take it very lightly. I've seen this myself, and by going to various states, there is actually very poor infection control in certain hospitals. Some in one hospital, donning was happening inside the ward rather than being done before entering the COVID ward, and also there was really no designated area or steps to really see that it is done in a proper manner. If your doffing is not done properly, you can actually get the infection while you're doing doffing. And it's very important that all steps are followed religiously as far as doffing is concerned. Similarly, I had gone to one hospital where inside the COVID ward, because of they had kept a juice counter, and if someone felt thirsty, he could take off his mask, have a juice and a drink, and wear the mask again. Again, this is not done if you're in a COVID ward. You can't take off your protective gear and have a glass of juice or drink something and then wear the protective gear. You are actually exposing yourself. But these are things which are happening across the country, and therefore I think infection prevention and control is something which is very important, and it's to protect our healthcare workers, it's to keep their morale high. It's also a strategy which I think has benefit in the long run, because it will help in decreasing other infections in the hospital if we have a good hospital infection control team. So I would actually ask all the centers for excellence and all the other hospitals to aggressively develop in their area an infection control team and have good infection control practices. So with this introduction, we'll start off with the topic of the week, which is infection prevention and control. We've been doing this aggressively for the last a few months, from almost February onwards. The infection control team here and the trauma center is regularly having training modules twice a day for all the staff, and this includes even the contractual staff, the guards, and the other contractual workers, so that everyone is well trained as far as infection control measures is concerned. So I'll start off by asking Dr. Purva Mathur to give the first talk, and then later on we can have question and answers.
Good afternoon, everyone. Thank you, Director Sir, for the introduction and importance, giving the importance of infection control, especially in COVID times. So I'll just briefly describe what we've been doing at Aims and how the other centers for excellences can somehow take some important messages from them. So we know that infection control is very important, and especially in pandemics, why it is important is because if we have a very large number of cases, we'll be actually overwhelming the healthcare facilities with a very huge number of patients. So if we have good control measures for a pandemic, we'll be flattening the curve and thereby minimizing that overwhelming of healthcare facilities. For airborne infections, especially COVID-19, which is transmitted by a respiratory route, we know that when a person coughs or talks or sneezes, this is the area 5 to 6 feet where there are these large droplets which are highly infectious, and that is why the distancing is very important. All the healthcare infection prevention measures have to really focus on this area because the larger droplets fall to the ground, and that is why it's very important that these careful precautions should be taken for cleaning of surfaces to clear these larger droplets, and the droplet nuclei are actually blown away by the air. So when we talk about infection prevention, we all know what are standard precautions. In addition to that, for COVID infection, we actually need to really focus on contact precautions like isolating the patients or cohorting them, limiting the movement of patients, and droplet precautions, which actually revolve around careful use of a very good mask, the face protection. Can't really underestimate the importance of hand hygiene, which is of paramount importance at all times when the patients are there in the ICUs or the wards. So, hand hygiene is of utmost importance. What we are doing at Aims, just 10 very important points which we have been highlighting at All India Institute of Medical Sciences and which revolve around good triage practices and some additional measures. So, to highlight on these additional measures, um, these 10 points actually revolve around good doffing practices, followed by showers by all healthcare personnels, supervised donning, a very good quality of personal protective equipment as per levels of care, regular cleaning and disinfection of doffing areas in ICUs and ward, appropriate biomedical waste management, separate routes for patients and staff in COVID hospitals, high quality continuing education for infection prevention, engineering modifications, admission and discharge criteria, and administrative structure with responsibilities to jobs assigned to various healthcare workers. So very important. I think the most important, as Director Sir said, is actually supervised doffing followed by showers. So we know that doffing is the most risk intensive procedure. So because doffing stations have the highest bioburden of virus, and therefore an infection control nurse or a buddy system helps in these COVID hospitals so that appropriate doffing protocol can be ensured. You can also have televisions displaying docking steps or posters displaying docking steps, and there should be adequate showering facilities after docking. If nothing is available, like a buddy system, we can have mirrors. So these are the docking stations at Aims where we have these supervised buddy systems for docking. Second important thing is supervised donning, because once you do proper donning, it ensures adequate protection during the duties. It also ensures proper doffing. So a central donning station with assisting nursing and posters for donning steps are very important, and we can have a central supply for scrubs and rubber shoes. So this is how the donning stations at Aims look with supervised donning, and these are the posters which are displayed everywhere so that healthcare workers can do donning. Then, very importantly, we should have high quality personal protective equipment as per levels of care. So, a central supply of these high quality PPE always helps. So, we have this PPE committee at Aims which regularly supervises and checks the quality, and that is how we ensure good quality N95 masks, face protectors, and all the PPE. So, this is the central PPE facility in which the committee actually checks all the batches and ensures proper supply. The Aims has also issued guidelines for appropriate use of PPE based on the level of exposure and what kind of procedures are being conducted. So anybody can access this site and go for the appropriate use of PPE and see. Then regular cleaning and disinfection of all the ICUs, wards, and docking stations. So round the clock, ensuring proper cleaning of not only the areas but also the washrooms, high touch surface areas. The ICUs should be wet mopped and dusted every 2 hours, and we can also spray the AC vents with hydrogen peroxide or alcohol ethanol combination. So this is how we do the supervised cleaning, including the AC vents and all the high touch surface areas. Appropriate biomedical waste management will be dealt by Dr. Gagandeep in the next lecture. Then we should have separate routes for patients and COVID staff so that there is clearly defined routes for patients, entry and exit of staff, laboratory samples, biomedical waste, laundry, and also handling of dead bodies. So there should be dedicated lifts, stairways, and corridors which should be marked for all these patients and non-patients. So this is how we have earmarked these areas and lifts for COVID and non-COVID patients and staff. Then, of course, high quality education, which should be given to all health cadres. So, we have developed our own protocols and guidelines, which are updated, and these are posted on the Aims website apart from webinars and online classes and trainings. So, these are the classes and trainings that we have been doing for all cadres every day. Engineering modifications like separate AHUs and ACs for COVID ICUs are very good. If they cannot be done, then we can have a suboptimal thing like adequate air changes in old AHUs. Total sealing of ICU doors, separate donning and doffing areas, showers, and signages are very important for ICUs. Then admission and discharge criteria, it's very important to have a very clear-cut triage policy where a suspected patient, group of suspected patients are to be kept because they have to be kept in one area till their screening result come. And if they come positive, then they have to be segregated into varied COVID care facilities like we do at Aims. The milder patients go to the NCI Jhajjar complex and the severe patients go to trauma center. The non-COVIDs can go to the respective departments. So this is how our triage facilities look like. We have well ventilated glass partitioned areas and the patients are kept there for 6 to 7 hours till their results come. They are sometimes very sick on ventilator. They can be on oxygen mask. And once they are confirmed to be positive, they are actually sent to the dedicated COVID care facilities. And then finally, a very strong administrative structures with respect to jobs and responsibilities, a top-down approach. We have the directors meeting every day in which micro planning is done and jobs are assigned to the various departments. There are committees made to look after all the various aspects of COVID care. Duty rosters are made, which are made for 14 days. Then there is provision for HCQS and personal use masks, which has been given to all healthcare workers, and 25% staff from each department have been given to COVID care areas, including the core departments from anesthesia, medicine, and IT. So these are the resources on the Aims website which can be accessed for healthcare associated infection prevention and all aspects of infection prevention in COVID care. Thank you so much.
So thank you, Dr. Purva, for the presentation. Maybe we can take a couple of questions which have been partly covered by Dr. Purva. So one of the questions, Dr. Lodha, is that should healthcare workers in non-COVID wards and operation theaters also wear PPE? This has been asked by the COA from Tamil Nadu. So can you help with what we have been practicing and
Yeah. So thank you, Dr. Ambuj. I think the issue here has been that at the institute we have had a policy where, apart from the core COVID areas where people who have been diagnosed or confirmed the infection are shifted, we have had a certain level of protection in all our inpatient services, which predominantly includes the respiratory protection, which means that the N95s were being used by all healthcare workers. If they were kind of doing aerosol generating procedure, nebulization, and so on, we had supplies of the face shields in addition, and they were using at least a gown is what they were using. And I think the benefit is that while we screen all patients who are admitted to emergency, there's still a possibility that some of them may turn out to be or diagnosed to be positive once they are shifted to so-called non-COVID areas. And if the staff are not really protected there, there's a fair risk of exposure, and a large proportion of staff actually may have to be quarantined, and that has happened in many of the healthcare facilities across the country. So I think at this time point, particularly when, let's say in parts of the country or otherwise where the cases are substantial, And in that setting, it would be worthwhile to offer a certain level of protection in all the areas, because it's not really possible to 100% say that somebody is COVID negative or this ward is COVID negative, as has adequately been highlighted by the real life experiences from different health facilities across the country. So we would suggest, as we are doing here, a certain level of protection to all healthcare personnel across various areas in the hospital.
Essentially, you need to triage your patients and decide your level of PP, right?
Yeah, so Dr. Purva did highlight that we have a certain level of protection or levels in terms. So I think something that cuts across all the levels is predominantly the respiratory protection minimum, which is using a N95 mask. And thereafter, whether you use an additional face protection like a face shield or face shield with goggles is dependent on, when you really move towards aerosol generating procedures or definitively COVID confirmed cases with when we are dealing with. So even in the usual ward setting, we would encourage that people, if they are intubating, they would use a face shield.
ईयरफोन देना एक.
Yeah. So there's one more question. Is that creating negative pressure in areas with split AC? I mean, how do you work on that?
So, as I said, airborne precautions are very important, especially with some of the recent references talking about airborne transmission. But in most COVID ICUs, it is not possible to generate negative air pressure. What is ideal is that if you have a newly constructed ICU and your AHU is modifiable, you can have 12 air changes per hour. But the CDC mentions that in older ICUs, where you cannot really modify or play around the air handling unit very much, even six air changes from the AHU are sufficient. And in some of the district hospitals, these queries keep coming quite often. So you can even have a cross ventilation. You have one door and one window with fans which are actually propelling air towards the patient, I mean away from the healthcare workers and towards some kind of window outlet. So when we talk about air handling, we have to really see from the perspective of India, where you may not have the tertiary care settings. So the ideal is 12 air changes. If some ideal is 6, even if that is not there, a cross ventilation with a fan which is put so that the air is blown towards the patient, away from the healthcare worker and out of the window. Negative air pressure is ideal. I mean, we have a burn center which has ICUs with negative air pressure and negative pressure, but it's not doable.
It may not be feasible in every ICU. You would like to add something?
In such settings where there may be a room or so, whether adding an exhaust is something that would help in overall ventilation, along with some fans and all.
Yes. So an exhaust with a fan can be adapted to that.
There's one more question, Dr. Loda, and it's been, I think, clarified with the ministry also, but this question is on current status of use of face mask with valves. So would you like to just...
Okay, I think, so we have broadly, when we are talking about N95 or equivalent masks, we have one with the expiratory valves and one without expiratory valves. The recent circular from the ministry, from what we understand, is primarily for the public usage. For public use, it's generally said that a simple 3-ply mask, or even there's a whole list of different homemade masks which would be good enough for them, because they're not really getting in close contact, or people who are confirmed positive, aerosol generation, and so on. And within that, it was mentioned that N95 of any sort type should be discouraged for public usage, particularly the one with valves, simply because the valves expiratory air kind of goes out. It may not come out with the same force as without a let's say without a mask, but it is still comes out without filtration. So for public use, lay people use, a valve mask should not be used, particularly anybody who's symptomatic is certainly a big no. And that same thing would be there for any symptomatic person. Now, coming back to the healthcare facilities, I think that's the key concern. So I think the certified N95, NIOSH certified N95 masks that we have available in the country, a fair proportion of them do come with valves. Now, if we are using it in a facility where everybody is actually using a mask, then practically, for our own protection, it is fine, absolutely okay. There's a small risk that, somebody may be carrying an infection, asymptomatic, and there's some risk of contamination of the environment. But if we are following the other measures, which Dr. Purva had nicely highlighted about distancing and other things, it probably doesn't increase the risk of infection. And to a great extent, we can say that from the experience that we have had from our, core COVID facilities, where the so-called infection rate amongst the healthcare workers working there, I think probably was lower than those who are working outside those facilities. So as long as we are able to adhere to the basic principles of other infection control measures, everybody is using a mask. People who are symptomatic do not use a valve mask. I think we are fine. Means it should not really be that it's suddenly that you can't use this valve mask. It's only that okay. If you had to choose between the two, yes, based on these criteria, you could say that we would prefer a non-valve mask, but a valve mask is not it's not contraindicated in that sense in our kind of a setting, is what our current take would be on the issue.
So we've got a couple of questions on the chat also. Manish, if you could take that. It's a question is, what is the advice once any healthcare worker is found positive as far as quarantine is concerned?
Thank you. So, any healthcare worker positive, as per guidelines, the management would be based upon the severity of symptoms. Obviously, if it's mild, and, very mild symptoms, would go for home isolation for 7 days. And so, this is about a positive. So, it has to be managed as in lines with what are the guidelines based on severity of illness.
And so the next question is again, Manish, if you could take that, and others can chip in, is specific precautions to be taken while aerosol generating procedures are done. It's been asked by the COE from Tripura.
Yeah, this is a very important aspect. The first thing that we try to do is avoid as much as possible any aerosol generating procedures. So, for example, if a patient is on ventilator, rather than open suctioning, closed suctioning is preferred. If a patient requires nebulization, we tend to replace it with MDIs and if available, a spacer. Now, next, some procedures may not be available. Let's say a bronchoscopy, then we try to do it in a separate procedure room, and minimum number of people who are required doing the procedure are around. And there are certain things like
Sir, sorry, we can't hear you. I think you're on mute. Okay.
Okay. So, first of all, the mode of delivery, we have to see what we are doing. So, in this condition, we are allowing a vaginal delivery also, although the rate of cesarean sections are more. And after a proper counseling, we can allow the baby to be roomed in with the mother. However, as we have to understand that currently the mode of transmission, currently there is no, a solid evidence of a vertical transmission from the mother to the baby, and neither is there an evidence of transmission through genital secretions. So, in that particular situation, the baby can be roomed in with the mother and allowed to breastfeed. But what is important is that we should be taking all respiratory precautions. That is, that the mother should be wearing a mask, hand wash, sanitization, and the baby should be keep a proper distance between the mother and the baby when the mother is not breastfeeding. So if we take these adequate precautions, then we can room in the baby with the mother, and actually the mother can breastfeed after in a newborn baby. So these are some of the basic precautions which can help in a proper newborn care.
So I think the points have been highlighted. There's been a guidance from the, I think, joints, I think Foxy, NNF and all in terms of what has to be done. So I think there are certain points around, let's say if there's a need for resuscitation, it's been advised that if possible, if it could be done in a room adjacent to the room where COVID positive mother's been delivered, there has to be a high level of infection control practices, disinfection in areas where, let's say, there may be a high, let's say, delivery rates or the load that they handle is high. And the rest of it would be dependent on the baby. So if the mother is doing fine after delivery, baby doesn't need any ICU care. At this time point, the recommendations are to room in with the mother for so-called advantages of breastfeeding and so-called being close. And the mother obviously, and there may be times when there may be other attendants who would need to help out the mother-baby pair. They need to take adequate precautions, which are general precautions about the respiratory, hand hygiene, a bit of distancing to whatever extent that can be done. So these would be the basic things and in the event that the baby is sick and needs ICU care, at this time point, there's a suggestion that if there could be a separate corner within the ICU and all, which could be created, or otherwise, which may not always be possible. This is kind of still based on possibility that there may be a small risk of so-called transmission to the newborn. As of now, the only isolated case reports on vertical transmission, and the recent paper kind of did seem to suggest that the placenta doesn't have the receptors for the SARS-CoV-2. So possibility may be low, and but till that's sorted out, if it's possible, it could be done. But otherwise, if it can't be done, then you just make sure that there's adequate distancing between two open cares or incubators and so on, and other general infection control procedures to follow. So I think that's what I would just like to add.
There's a just related question is when do we test the baby if mother is positive? Do you need to do that? And
So, as per the protocols, there are the various protocols which are available. So, generally, number one is that we can test at the time of birth by a nasopharyngeal swab within 24 to 48 hours. So, that is one protocol. Or if a patient is, if the baby is completely asymptomatic, the testing could be done within 5 to 7 days. So, this is what the protocol is generally followed, but preferably within 24 to 48 hours. That is also indicative of a vertical transmission because that would also tell us, but within 5 to 7 days, because that is the general time when the babies are there in the hospital after delivery. Yeah.
Yeah, just to add to that. So I think the first testing is primarily to look at possibility of vertical transmission, which the current evidence kind of is not very supportive, but I think till we have a definitive answer, that may be continued. The day 5 to 7 is, I think, based on what we do for adults with exposure, that the maximum rate of pickup may be around day 7 or so, and that may be reason. In a child who continues to be asymptomatic, if a child is symptomatic, then we test the child earlier, if at all we need to do that. Yeah.
one question which we've got, maybe Dr. Purva, you can take is, what is the probability of catching COVID-19 in absence of glass partition while checking patients if we wear PPE in primary health care settings?
So, if you have proper PPE, as Lodha has said, that most important and something which we can't really compromise is the face protection or the respiratory protection. So, if you have protected your face with a properly fitting N95 mask and you have something like a face shield, that more or less takes care of, and you have proper distancing. I mean, the patient can be seated even if you do not have a glass partition. Like we are about to open, we have actually opened the OPDs, and there was a lot of discussion of whether you should have plastic sheets or barriers like that, which are not very feasible because you have to actually examine the patient. So what is required is basically respiratory protection in terms of proper mask, face shields, and an impervious gown if you actually feel that you have to, there is exposure to body fluids and things like that, but no need of glass barriers.
Yeah, I agree. I mean, if you're taking adequate precautions, we've seen, in fact, in the COVID areas, we've had very negligible
Yes,
transmission.
very few
And
healthcare workers
most of our
actually have
cases come from non-COVID or
non-COVID, yes.
communities. So if you're taking right precautions, I
Yes.
think So you can keep asking your questions, and maybe you can ask some direct questions in the end. So before I go to the next presentation, which is on very important part, how do you handle this bio waste management? And just one question to Gagandeep, which is there related to the earlier, and then you can go to the presentation. It's like on cleaning and disinfection of MR suits after imaging of COVID positive patients, and how do you disinfect stats, BP apparatus, etc. in COVID wards?
So actually, there are two scenarios related to cleaning of MRI or CT machines. One is that if the healthcare workers are already prepared, or they know that COVID suspect or COVID positive patient is being brought in, so the patient definitely needs to wear a mask, and the healthcare workers need to have a bare minimum personal protective equipment, which would include the N95 mask, a face shield, at least a gown, and a pair of gloves. So that is the minimum level of PPE that the healthcare worker would use. And then the patient table on which the patient would be laid must have either disposable linen or separate linen, which would be handled, taking care of the COVID-19. And once the MRI or the procedure has been done, the cleaning or the disinfection of the machine is usually what we say is that you should contact the manufacturer of the machine and ask them what disinfectant would be appropriate to be used on that particular machine, and that is to be used so as not to spoil it. And then there is another scenario if we really don't know if the patient is COVID positive, and later on after the procedure has been done, you come to know that the patient is COVID positive. So for that, basically the complete sanitization of the machine has to be done, and depending upon the level of exposure, if it's high level exposure of the healthcare worker, they need to be quarantined, and healthcare workers who are low level, who have lower level exposure, they need to watch out for the signs and symptoms. So basically the bottom line is that the manufacturer of the machine needs to be contacted for the detailed procedure and the disinfectant to be used. So I'll move on to the presentation related to the biomedical waste management in context of COVID-19. And we know that the biomedical waste management and handling rules, they came into effect way back in July 1998, and they were amended recently in March of 2016. And since then, since the COVID-19 pandemic started, there have been multiple revisions that have been brought about by the Central Pollution Control Board. And recently, just 2 days back, on the 21st of July, the fourth revision was released, and the CPCB has been doing a great job of revising the recommendations depending upon how the scenario has been changing. So the biomedical waste management rules of 2016, they apply to all persons who generate, collect, receive, store, transport, treat, dispose, or handle biomedical wastes. And examples of these are hospitals, nursing homes, clinics, dispensaries, pathological laboratories, blood banks, health camps, forensic laboratories, research labs, etc. So all these, any lab or any area producing biomedical waste needs to follow the biomedical waste management rules. The revision in context of COVID-19, it basically highlights waste and segregation and handling related to hospitals. Disposal of PPE has been a major change or major highlight of these guidelines, and disinfection protocols. Also, especially in the recent revision that we have seen, they have focused more on the quarantine and home care facilities, and also for sample collection units in the community as well. And they also deal with the responsibilities of the common biomedical waste treatment facilities for the COVID-19 and the STP and ETP monitoring. So key points related to any biomedical waste management, they remain the same, be it a non-COVID or a COVID situation. So the backbone of biomedical waste management is proper segregation. And collection and transportation is a vital link between generation and treatment of waste, so that nobody gets exposed, and even to prevent the misuse of whatever is being produced. And it's very important that common biomedical waste treatment facility is there, and these are authorized by the CPCB for the handling and treatment of the waste. Training is an integral part of the biomedical waste management, and as we have been doing, the infection control committee and the members regularly train and apprise all the healthcare workers regarding how the segregation has to be done, because segregation at source is again one of the key points. And again, recently in the 2016 rules, this was included that the microbiology laboratory waste and blood bags, these need to be pre-treated at production. So I'll just go through the basics of the biomedical waste segregation, and then I'll highlight what changes have been made according to the COVID-19. So all the general waste that is produced in the hospital or any healthcare facility goes into black bags. Human anatomical waste, the chemotherapy drugs, soil waste, expired or discarded medicines, even microbiology waste, it all goes into the yellow bags. Contaminated plastic wastes, which are basically need to be recycled, they are discarded into the red bins. And the sharps, including metals, they go into the puncture proof, leak proof containers, which are basically white in color. And also the glass vials and even other metallic products, they can be discarded into cardboard boxes, which may be blue or white or blue in color. So now one of the highlights of the recent changes that have been brought about in the fourth revision of the biomedical waste management is regarding the discarding of the PPEs, which is very important because these have to be segregated at source. And anything containing large amount of plastics have to go into the red bag, because these are mostly reused or even shredded and put into landfill. So used goggles, face shields, splash proof aprons, plastic coveralls, hazmat suits, nitrile gloves, all they go into the red bag. Whereas the used masks, including triple layer mask, the N95 mask, head cover or the cap, shoe covers, disposable linen gowns, non-plastic or semi-plastic coveralls are to be segregated into the yellow bags. Another important point to be remembered is for non-COVID patients or people in general public, waste masks or gloves in the general households, these need to be kept in paper bags for minimum of 72 hours as to kill the virus. And these then can be disposed of in general solid waste after cutting the same. So it's important that this step is to be done by people who are not infected, but they are just using masks or gloves to protect themselves. So that can be done. And as far as the COVID-19 areas of the hospitals are concerned, the changes that have been brought by the biomedical waste rules, one is, and it's very important, is that a double layered bags are to be used. So which should be of adequate strength. And this is to be done, basically to prevent any leakage and exposure of the healthcare workers due to any body fluids which are contaminated with the COVID-19 virus. Then dedicated collection bins labeled as COVID-19 are to be used for temporary storage. Bags, bins, trolleys, all which are carrying the biomedical waste related to COVID-19 have to be again clearly be labeled as COVID-19 waste while shifting them from the ward to the disposal site. Then again, a very important point is that every hospital or a healthcare facility or any facility having, who are managing COVID-19 patients should have a nodal officer. And the nodal officer is responsible for all operations related to the biomedical waste management. And again, another thing is that all facilities need to be, registered with the CPCB's app, which is the COVID-19 biomedical waste app. And the amount of biomedical waste generated daily, it needs to be updated on this app. As far as the biomedical waste that is being generated at the quarantine camps or home care. Again, any masks, gloves, tissue, swabs, syringes, or medicines that are being used or being used on the patient, these are part of the domestic hazardous waste. Also known as the biomedical waste related to the household. So these need to be discarded into yellow bags, and mostly, anybody can understand that routinely we don't have the yellow bags with us. So the urban local bodies who are related to the general waste management, they are supposed to provide the quarantine camps or the household, especially the households, with the yellow bags for the disposal. Then again, the quarantine camps again need to have a nodal officer, and they again need to update the app routinely. And the general solid waste and biomedical waste is to be handed over to persons identified by the urban local bodies or the designated, they can even be handed over at the designated deposition centers. And urban local bodies should make sure that there is at least daily collection of the segregated solid waste. Once the biomedical waste is generated at site, it needs to be transported. Again, we need to keep a record of what amount and how much of each type is being produced and how it is being transported. And then again, one step which is being recommended either in a hospital or a quarantine facility or even at home is whenever you are generating waste, the bags should be disinfected with 1% sodium hypochlorite whenever it is being handed over to the person who's taking it, and so that per chance there is contamination of the outer surface of those bags, you are disinfecting it. And again, adequate PPE should be worn by the personnel who are transporting, which again should include at least a waterproof gown, the N95 mask, goggles, thick, sturdy gloves, and gumboots. And again, another point which I'd like to highlight is that the treatment and disposal should be done immediately on receiving at the common biomedical waste facility, and that is one of the reasons why we are labeling it separately, so that it is easy to identify, and they should be these the COVID-19 biomedical waste should be given priority for treatment. If you look at just how the waste is treated, just one slide on this. The yellow, which are the non-chlorinated bags, they are incinerated. The red, again, these days we are using non-chlorinated red bags. Mostly they are autoclaved, or they can be treated by microwave. The blue waste, or the blue waste in the blue bags, they are managed by shredding or recycling, and the waste in the white bag again is can be, or white container can be autoclaved and shredded and recycled. Liquid waste, again, it should be managed through the effluent treatment plant or the sewage treatment plant. Although there is very limited, evidence that infection can be spread through these, but still, it's recommended that whoever the personnel who are there, who in the ETP and the STP, they again need to wear appropriate PPE so that there are least chances of acquisition of infection. Also, the treated water that is produced at the STP should not be utilized for any other purposes. It should simply be discarded. Thank you so much.
One related question is on the use of UV light lamps for disinfection. So would you just like to complete?
So UV light, it actually depends upon like the UVGI lamps are being used for many purposes. It can be for the disinfection of the air. So we have the UVGI lamps placed in the AHUs or the exit, vents. And UVGI or this UVC rays have also been used to disinfect N95 masks and also for rooms. But one important thing to remember about UV rays is that anything which is in line with the rays, only that is going to be disinfected. So if there are any crevices or any folds in whatever we are trying to disinfect, those will remain, the virus will remain in those areas. So it's a little tricky to use UVGI, and plus it's expensive.
Thank you, Gagandi. I think a lot of clinic questions related to clinical care also which have come in. One of them is related to gynae ops, and we have had a very active department right through the pandemic. The question being asked is, what are the specific precautions for obstetric and gynecology? We put it from the Pondicherry.
So thank you for the question. I think that's a rather a very broad question, and I would like to answer it like a bit stage wise. So you see, when a patient, so during the COVID pandemic, I think a lot of issues and a lot of have been raised regarding pregnancy care. So if you divide it, I would say the antenatal, intranatal, and the postnatal care. So during the antenatal care, I think first of all, we are so used to having some 8 to 10 visits, and WHO has suggested like 8 visit model for antenatal care. But gradually during this pandemic, we have moved towards a 4 visit model, in which we should say that we have to reduce the number of visits. So we should reduce it to a 12, 20, 28, and 36 week visit. So first of all, reduce the number of visits. Also, during the antenatal visit, reduce the duration of visit. We should actually focus on the more important things, and also a slight move towards teleconsultation platforms if available. So those are something which we have learned during this pandemic. We have developed those things if possible. So some of the changes in the antenatal care. Also, 28 weeks onwards, we have asked our women to monitor her blood pressure at home, weight at home. So these are some of the things. And also do the 5. So when you are at home, you maintain social distancing, avoid touching your hair, face, maintain hand hygiene, maintain respiratory hygiene. So even for pregnant women, these general precautions do apply. Also, during an suppose there is some problem, so do not panic, contact your healthcare provider. We are so used to rushing to the hospital without planning, but in a COVID pandemic, what we've really learned is just do not rush. First, call up your hospital. That's very important, because there will always be a specified area where you will be always looked at first. So these are some of the things. So always first contact the hospital where you are going to be seen at. So planned antenatal care is something which has changed during this pandemic from a completely unplanned care. Also, during the intranatal period, that is during the labor and delivery, something that is something that we have to really look into. So when you come into the labor room, during the labor and delivery care, overall the principles of labor and delivery will not change, but something that really needs to be seen is that you might not be given a birth companion. You will be there. So if you are a suspect or if you are symptomatic, you will be in an isolated room. So during that labor and delivery is a time of stress. Even that time, although the healthcare provider will be there, so it is really important to understand that you might be there in an isolated room. The labor and delivery will be taken care of. You will be eligible for a normal delivery or a cesarean section, but there might not be a birth companion. The process of induction and monitoring of labor and delivery remains the same. And as I mentioned before, after delivery, your baby, if you are negative, your baby will be roomed in with you. Take proper precautions with respiratory precaution. Breastfeeding can be allowed, and you will be discharged depending on hospital policy within 2 to 5 days. So I think this broadly will summarize the care for an antenatal pregnant woman during delivery. So as far as gynae is concerned, I think nobody is actively doing gynae in the present time except for a malignancy in that situation, or a cancer situation in which you would need to be operated, but provisionally in specialized centers. So thank you.
Yeah. And, one related question was, what do you do when the newborn is positive and the mother is negative? So maybe you and Dr. Lodha.
So would you start?
Yeah, I think this situation is more often for older children, typically, because they could be, and we have had these instances where the kid is positive and the mother's tested negative. So how do we manage? So, and many times, if the and scenarios where the child is just having mild or moderate symptoms, a young child particularly, it would not be possible to keep the child alone in any medical facility. So the mother would have to be, accompanying the child. The concerns obviously are the risk of infection to the mother from the child, and also if the kid is admitted in a so-called COVID ward area, then she's likely to get exposed to other people. So a desirable thing would be to have the kid admitted along and the mother looking after in a isolation room where some of this exposure to the mother from other COVID positive patients could be reduced. The mother should be using respiratory protection. Use a N95 mask in this particular setting. Maybe, if possible, use a simple face shield in addition, particularly if she actually has to be in so-called COVID ward area. And the hand hygiene and other things that other infection control practices. In the case that there's no option, but let's say the mother has to be in an area where so-called, you have a cubicle where there are 4 patients. In that setting, she would need an additional, maybe so-called parts of PP, which may include a gown. And using nitrile gloves is what one would be suggesting. But it's not easy to kind of say that looking after a child alone, a young child, particularly a child who's under 10 and so on. ICU setting is different, but apart from that, we would have to have the mother or one of the attendants.
Yes, so I would like to add that we've had instances like this, and the mothers have actually taken care of their babies. So, I mean, there is not much of an option regarding that. And eventually, if the respiratory hygiene is being maintained and, hand hygiene, we are taking care of it. So, we have seen mothers doing that. So, that's the best way out right now.
Manish, one of the related questions which I asked you is that what are the time period for quarantine of high-risk contacts of COVID positive healthcare workers?
Okay, so the question is probably related to family of the COVID positive healthcare worker. So high risk contacts means two things. Time period of quarantine is 14 days, and the high risk contacts needs testing if they become symptomatic anytime. Even if they remain asymptomatic, since they are high risk contacts, they should be tested once between day 5 and 10.
Okay. And one more question which we are getting is the peculiar situation of an asymptomatic healthcare worker being positive for 1 to 2 months. So when can they get fitness to join duty?
Well, most of the healthcare workers who have been detected to be asymptomatic, many times they are pre-symptomatic also, they do develop some mild symptoms. Now, as per guidelines, if they have mild disease, as per the recommendation, it is 10 days from symptom onset plus 7 days, 17 days of total period of isolation. And there is no need for repeat testing. As by now, we very well know that this PCR picks up dead virus particles, and there is no, that's why this has been done away. The recommendation has been done away for retesting in mild cases and even moderate cases.
Right.
So I think the virus has been, means at least on PCR positivity has been documented for weeks together in some scenarios. I hope the healthcare worker doesn't have any so-called any immune suppression or immune deficiency, which may be a contributory factor which one may just quickly look at. But I think we need to do away with the practice of repeated testing and documenting a negative test regarding discharges or regarding fitness to join back. So I think that's a countrywide policy now.
And does the CT value contribute, you think, in the RT-PCR?
So I think the CT values are just kind of give an idea about the viral load. A low CT value indicates the viral load is high. But one thing what we need to remember is that whenever we're taking a swab sample and putting it into the transport media, end of it, it's an unspecified dilution. We really don't know that the swab is going to pick up the same amount of material from 2 people, but it's indicative. So a high CT value, typically then that would be reported as a negative one or indeterminate rather than this. But even if it showed up a CT value, I think whatever data that's come out in various studies seems to suggest that the probability of viable virus substantially goes down beyond 10. And that's the reason why even the discharge criteria for, or recovery criteria have been modified. So, and removed the need for, documenting a negative test have been done away with.
One question is on the recycling of PP. It's a tricky one. Maybe Dr. Purva and Dr. Gagandeep can take. It's on use of EQ or autoclaving for recycling PP.
So ideally, that is what we say, because the viral exposure is very high, especially in the COVID areas. It's better not to reuse, but in exigency, if one needs to reuse the PP, we must make sure that the procedure or the method that we are using should not destroy the quality of the PP. And most of the PP that, or the coveralls especially that we are using, they are polyethylene or polypropylene in the material. So till date, whatever literature is available, one of the best methods are either using hydrogen peroxide vapor. That is one. And UV has been used, but specifically for N95 masks, not really for the coveralls. So ETO, it's not recommended because there is some level of residue that is left behind, and it needs a long duration of aeration, and it's very irritant if any amount is left behind. So hydrogen peroxide vapor generally is supposed to be cheap and doable even at the peripheral level.
Yeah, so I think I would just like to add, as I think Gagan highlighted, that this is only as a backup mechanism. And I think thankfully at this time point, the country is kind of having, a reasonable supply of PPEs, particularly the gowns and the coveralls. N95 also, I think the supply definitely is, much better. And if we have to, then I think hydrogen peroxide vapor is what is there. And we need to know that the equipment for this is different from the usual fogging that is often done in many healthcare settings with hydrogen peroxide. So if at all one has to go in for something like this, the equipment and the protocols are different. And I think the ministry has had SOPs developed for this.
Yeah. So the other question is on how
mostly what is being done is that the stationery is just kept in separate room for around 5 days, which will take care of the viruses by it will kill the virus by the method of drying. And thereafter it can be especially for the records and the files, if you are talking about, some people definitely talk about using UV as a method, but we again must remember that UV only disinfects the surface, so it won't be able to take care of the multiple papers that are inside the file. So it's good to just disinfect maybe a single sheet of paper, and then again both the sides have to be disinfected even in a single sheet of paper. But I think just holding it for 5 days is the most easy method. Again, and one more method that is available in literature is that you can maybe put it in a hot air oven for around 70 to 80 degrees for half an hour, and that might take care of the virus.
And maybe additionally, I think for the safety of the staff who kind of carrying the record from one place to other, they need to take adequate precautions in terms of having, maybe you have their gloves, hand hygiene and other things. I think that's predominantly should be able to take care of this concern. And I think, and within this setting, a lot of centers are also trying and moving towards electronic health records and so on, which kind of does away with the so-called need for having these paper trail.
there's one clinical question on clinical management. Manish, it's from Kerala, which says that in states where remdesivir is not available, can we consider a combination of HCQ and favipiravir as being done in UAE?
So this favipiravir thing has come up after a small publication from Japan. It was a 2-arm study. So they used just 35 patients in one arm and 45 in another, favipiravir versus lopinavir, ritonavir. They looked at just the viral clearance, and the study didn't really have solid clinical endpoints and definitely was not adequately powered for it. There are some other ongoing studies, but the current evidence that it is there, we don't really think that favipiravir, we really need to have a relook at the data, new data, before we can decide upon use of favipiravir. SCQS, yes, definitely we do use as per the national guidelines. But one point to remember, whenever we are using antivirals, it has to be used early in the course of disease, first 7, 10, 12 days. That is true for remdesivir, that is true for SCQS. So rather than using in severe cases, it should be started early in mild cases with risk factors for severe disease or in moderate disease. Now, if you look at data coming from recovery trial, there was 25% mortality among patients who were given HCQS, And in there we see that majority of patients, even severe patients, were given SCQS. Now, giving SCQS in a severe patient may have its own side effects. The severe patients will be may be having myocarditis. They will be on vasopressors, inotropes, and so the toxicity of SCQS can go up in these severe patients. So always an attempt should be made to start it early in the disease course.
Right. There's a question on remdesivir in children, Dr. Rakesh.
So again, I think the data are still kind of coming out, and the US FDA has kind of authorized emergency under that EUA criteria. The currently recommended doses are for, it can be used for children above 3.5 kg weight till 40 kgs. The dosing is 5 milligram per kg on day 1, followed by 2.5 milligram per kg day 2 onwards. And beyond 40 kg, they use the adult doses. I think that's 200 milligrams on day 1, followed by 100 milligram daily, is what is currently recommended. And you need to, monitor them, the hepatic renal function, and some dose adjustments may have to be done. So that's again, and the indications kind of remain the same as is for adults. You're kind of talking about moderate to severe disease early in the so-called course of the infection.
Yeah, right. The other question is on the role of subcutaneous tocilizumab and its equivalence to intravenous tocilizumab. Manish, would you like to take that?
So recently, the subcutaneous form of tocilizumab has been launched in India around a month back, and this question has come up since then. But what we need to see, the corollary for using tocilizumab in COVID-19 has come from the CAR T cell associated cytokine release syndrome. And the indication for the indication which it was used in cytokine release syndrome, it is indicated only the IV formulation is indicated, not the subcutaneous. If we look at the pharmacokinetics of it, though the bioavailability of subcutaneous tocilizumab is good, it is 80%. What we look at is the peak concentrations. So studies have done and looked at it. With the IV formulation 400 milligram, the peak concentrations are around 60 microgram per ml, and with the subcutaneous 162 milligram that is there, the concentrations is around 8 microgram per ml. So the concentrations achieved with the IV formulation is around 7 to 8 folds than that of the subcutaneous form. And when we are dealing with a life-threatening situation, when we really want to have a very, very quick effect, preventing intubation and all those things, I think it is better to go with the IV formulation. So there has been an Italian study, I think around 180 patients, they have equal numbers, 90 each of for subcutaneous and IV formulations. And in fact, the authors have pointed out that they use subcutaneous formulations because they didn't have access to enough of IV formulations. And to circumvent these pharmacokinetic issues, what they did is that they gave 2 injections of subcutaneous. So the subcutaneous pre-filled syringe comes 162 milligram syringes. So they gave 2 injections at a time, but they did really point out that there may be erratic absorption issues, particularly in severely ill patients. So overall, it is better to stick with the IV formulation.
Yeah, thank you, Manish. One more question is on the use of plasma therapy in management of COVID patients. Maybe since Professor Gloria is here, or Manish.
So unfortunately, there are no guidelines because effectiveness is yet to be proven. Though there is a very strong rationale for using plasma therapy, convalescent plasma therapy. And again, we have to remember that this is basically an antiviral property that we are trying to exploit. So it is better off being used earlier in the disease course rather than later in severe forms when the patient is ventilated and has severe ARDS. So though there are no guidelines, if you look at the protocol the ICM has come with, so an ideal candidate to receive convalescent plasma therapy is a patient early in the disease course, maybe within 10 to 12 days of symptom onset, who has a moderate COVID, that is, he's requiring oxygen and the oxygen requirement is going up. So this is the ideal candidate. But since one thing also we need to remember is that there are no side effects per se of convalescent plasma. So the benefit, whatever it may be, should not be devoid. The severe patient should not be devoid of it. They may also be given convalescent plasma. But since this is a commodity, it is not available very freely. So we need to prioritize it. And so moderate patients who are worsening oxygen requirement may be the first people who should be receiving plasma therapy.
So I just agree with that. I will just say that what Manisha said is important, that we first issue is that if you're looking at convalescent plasma, it has to have enough antibodies. So all patients do not produce enough antibodies. So taking a patient as plasma without testing for antibodies may not be good enough, because literature from abroad suggested that almost 1/3 of patients, when they were taking their plasma, did not have enough antibodies for it to be actually good for as convalescent plasma. Utility is more in the early stage, more moderate cases going on to severe cases. One other study actually found that in patients who were more severe or in advanced stage, they had already enough antibodies in the plasma, and therefore giving convalescent plasma may not have been that useful in later on, because after some days the body itself will start producing the antibodies, and therefore the utility may be limited. The data is limited. There is really no strong evidence to say that it really works. So it's something which you must keep in mind. It's not like a magic bullet, and therefore convalescent plasma is not something which has been shown to make a dramatic difference. The study in JAMA did not show a mortality benefit, and one study which is in preprint was also stopped because the interim analysis did not show a mortality benefit. So it may have some role, but I don't think it's enough to say that it has a dramatic role.
Right. Thank you. So the one question is on healthcare workers at Aims. Are healthcare workers provided quarantine facility on campus during and post COVID duty?
So I think once the staff are taking due precautions and all PPEs and all that has been provided, there are no specific recommendations to have them off duty after so-called the duty hours in the COVID area or a definitive quarantine. And we have been following this policy, and as we highlighted earlier, the staff who have worked at all the healthcare staff, the core COVID area, if you look at the healthcare workers testing positive, that is definitely lower than if you look at the staff in rest of the areas, be it they're getting it from their where they live, or the casual contacts that they may have had. So as of now, there's no quarantine policy for people who have worked in the COVID areas. If there is an inadvertent exposure in terms of any exposure, then the due guidelines of defining whether it's a high risk contact versus a low risk exposure, and accordingly the quarantine would be advised thereafter.
So the one more question on the chat is: shall we wait to start remdesivir if patient is already on HCQ?
So basically, remdesivir is a prodrug, and HCQS by its mechanism of action makes its activation a little difficult. But we are dealing with an acute situation here. We don't know how much of it is affected. We should not be waiting for it. As such, there are no side effects. It's just about activation of the drug. So we should be starting it straight away and not really waiting for a few days.
You don't have to wait for some time and then restart it. Normally, in moderate to severe cases, we are not giving hydroxychloroquine, and therefore remdesivir can be given there. There are some. There used to be initially some papers which suggested that both may should not be given together, but as per the guidelines, also we're not giving it together.
So the related question is on the new drug of itolizumab and its role in COVID management.
Tocilizumab is like tocilizumab. It's an anti-IL-6 drug. There is some limited data about it having been used in India. It's basically a drug used for psoriasis, but the initial data from India did suggest that it may be beneficial in cytokine storm. So again, it is not something which is a major game changer. You have to be very careful when you use these drugs, because they are double-edged swords and they sometimes can predispose to opportunistic infection, including fungal infection. So one has to be careful as far as the management of COVID management, their status in COVID-19 is concerned. It's an anti-CT6 drug.
Yeah.
So there are some couple of questions on rapid antigen testing, sir, and one is on its sensitivity and its role in testing healthcare workers after COVID duties. Role of doing rapid antigen test for healthcare workers after COVID duty, and what is its sensitivity?
So rapid antigen testing is basically a test which has a higher yield in symptomatic individuals because it picks up if test is positive, the chances of test being positive depends on a high viral load. So its utility in asymptomatic individuals being positive is much lower. If you have people who are having classical symptoms, your positivity can even be up to 70 to 80%. But if you're looking at a large number of asymptomatic individuals, it may not pick up the infection because if the viral load is low, then this test tends to be negative. Purva, if you want to add anything?
I agree. We had evaluated this test at Aims at a time when Delhi was facing a peak of infection. So at that time, probably a lot of patients had a very high viral load, and we got a moderately good sensitivity. The test has a very high specificity. So it is very good for ruling in a disease. It's almost 99 to 100% specificity. So if the test is positive, then you can actually be very sure that the patient has COVID-19, and that actually shortens the time to triage. I mean, if there is a very long interval of patients to be put in a screening area and the reports take a very long time, like from a district hospital, or you have to keep for 2 days, that time is shortened if you have a positive report. But as sir said, the sensitivity is a problem, especially in asymptomatic patients. So healthcare worker screening through this test may not be a very good idea. It is better for symptomatic patients.
Yeah, thank you, Purva. There's another question which we actually dealt yesterday extensively in our national grand round on COVID. It's if the Conrad score is 4 and the patient is asymptomatic and RT-PCR is negative, can the patient be taken up for general anesthesia?
So I think sometimes you have to look at the clinical radiological profile, and in many patients you may have a classical radiological picture based on the X-ray or CT, which suggests COVID-19 infection, and the clinical profile also suggests that the person may have COVID-19 infection, but at times the RT-PCR test may be negative. Such a situation, unless it's an emergency surgery, I would say that you defer the surgery because there is enough data which suggests that the morbidity and mortality is much higher in patients who go in for surgery who have underlying COVID-19 infection. A paper published in Lancet Respiratory Disease actually showed it to be of the tune of over 30% mortality. So I think we need to be careful for elective surgery if you are having a strong suspicion of COVID-19. If it's an emergency surgery, you will have to go ahead, but then you have to take proper precautions as far as PPE is concerned for the healthcare workers. So don't just go by the report, look at the entire clinical radiological picture also. And we had presented 2 cases yesterday in the national grand round showing 2 of our experiences where the patient was initially negative, but because the radiological picture was so classical, we did not shift the patient to a non-COVID area and tested the patient again and turned out to be positive.
So one question which was partly taken up is on how long the asymptomatic patient will be taken to be cured by its own if he never develops COVID symptoms.
How long will asymptomatic patient take to be cured by its own? So asymptomatic patient basically mean how long is he non-infectious? How long is he infectious? Because if asymptomatic is already all right. So what the data suggests is that if you are asymptomatic, you become non-infectious by the 7th or 8th day, and we usually have a cutoff of 10 days, and that's why the guideline also mentioned that you don't need to get yourself tested, and you can sort of if you're asymptomatic for 10 days, it's unlikely that after that you are infectious, and your RT-PCR may still be positive, but these are non-viable viruses which are being excreted and they are not infectious. Therefore, the guidelines currently don't require you to be tested after the 10th day, and it's presumed that you are non-infectious after 10 days of the test being positive if you are asymptomatic. view of the recent Sero survey in Delhi that found very high levels of asymptomatic infection, what are the public health implications for infection prevention? So yes, the Sero survey, which was done in people who did not have, who were not diagnosed to be COVID positive by RT-PCR, showed almost 23% positivity in Delhi, which is could happen in various other areas which were hotspots a few weeks or months ago. It only reinforces the fact that we have to continue to maintain social distancing, wearing a mask, and hand hygiene, because you may have a large number of people who are asymptomatic in the community and without their knowledge may be spreading the disease. So what we usually say is presume in a hotspot, presume everyone is positive unless proved otherwise, and take precautions as you would if you were in a environment where there were positive individuals also. So I think it's a lesson for all areas where cases are now increasing, that presume everyone is positive and take your precautions, whether you're outside or in the hospital.
I think we're coming to the end of the time. So if anything from the ministry or anything else anybody here wants to add, or we can wrap
I
up
could
with that,
ask Dr. Garg, Dr. Rajiv Garg, DGHS, if he has any comments to make from the Ministry of Health and Family Welfare.
Yes, first of all, I congratulate the whole team for solving so many doubts and giving a very good, lot of good take-home messages. And of course, the biggest take-home point, because the theme of today's discussion was infection prevention and control. So I think we have discussed almost all the aspects from various angles, whether it's gynecology, surgery, pediatrics, and the theme has been well covered. And I think we should all, as healthcare workers, wear the proper PPE whenever we are in the hospital, and that will prevent the morbidity in the healthcare workers. After all, we are the ones the nation is depending on. All the various teams who are here today should take this very seriously, and congratulate again the Aiims team for answering most of the queries very nicely. Thank you.
Thank you very much. And I'd like to just take this opportunity to thank everyone. And it's been a learning experience for all of us. So thank you for logging in, and we hope to continue this Center of Excellence webinars. So I hope to see you again in the next webinar. Thank you very much.
Thank you.